encouragement and support in preparing this presentation. I also truly appreciate all of you for being here today. As mentioned, the topic I'll be discussing is patent ductus arteriosus. PDA has long been a topic of great interest and complexity in pediatric cardiology. Despite being well-known condition, its management continues to evolve with emerging evidence, new technique, and ongoing debate. It remains a clinical challenge that demands both careful judgment and up-to-date knowledge. So the presentation is primarily based on recent articles from American Heart Association that offer a valuable insight into the current understanding and management of PDA. It was recently published in February of this year. I will be highlighting the key points from this paper throughout this talk. Here is a brief overview of the topics we will go through today, inshallah. So to begin with, let's briefly review the key aspect of PDA. In fetal life, the ductus arteriosus play a vital role by connecting the proximal descending aorta to the pulmonary artery, allowing blood to bypass the non-functioning fetal lung and instead flow to the placenta for oxygenation. After birth in term infants, the ductus typically closes spontaneously in over 90% within the first 48 hours and nearly all by 96 hours. However, in preterm infants, especially those born before 26 weeks of gestation, this closure is often delayed due to structural and physiological immaturity. In fact, the median age of closure in those infants is around 66 days, and over a quarter might still have PDA at term equivalent age. The clinical impact of PDA varies depending on its size and the infant overall cardiopulmonary status. While some PDA resolve without intervention, others can persist and lead to complication even into childhood or adulthood. Management remains a point of debate with no one-size-fits-all approach. It requires a careful evaluation of underlying mechanism, possible genetic factor, clinical presentation, and available treatment option. To understand PDA more deeply, we need to look at its embryological origin and anatomical context. The ductus arteriosus arises from the distal portion of the left sixth embryonic aortic arch, while the proximal portion of the sixth arch forms the branch pulmonary arteries. As the fetal development progresses, certain part of the embryonic aortic arch innovulates, while others persist. In normal development, the distal left sixth arch persists and becomes the ductus arteriosus, forming a bridge between the left pulmonary artery and the proximal descending aorta. Meanwhile, the right-sided structure regress, leading to the typical left aortic arch. This transformation takes place during the first 8 weeks of gestation, and the anatomical position of the ductus is a key. It connects the main pulmonary artery to the descending aorta just beyond the origin of the left subclavian artery. However, the ductus arteriosus becomes pathological if it remains patent beyond the neonatal period. Its size, shape, and position can vary significantly, which in turn influence its hemodynamic significance and the challenges it presents in both diagnosis and management. Now let's take a look at the anatomical variation of PDA configuration, which are important, as I mentioned, both diagnostically and when we're planning intervention. It can present in several forms. Type A or conical, it's the most common form with defined aortic ampulla and narrowing at the pulmonary artery end. Type B, the window type, is short and wide with constriction located at the aortic end. Type C, tubular, showing no narrowing at either end, making it continuous channel. Type C or saccular has a constriction at both aortic and pulmonary end with wide mid portion. Type E is elongated, usually narrow with constricted pulmonary end. Type F, often called the fatal type, is typically seen in preterm infants. It is long, wide, and tortuous, making it particularly challenging to manage. This configuration can significantly impact the hemodynamic effect, diagnostic imaging, and choice of closure method. So recognizing them is clinically relevant. Understanding the mechanism that regulates the ductal patency and closure, helps explain why some ducti remain open after birth. The Ductus arteriosus has an intrinsic tone, meaning it naturally tends to constrict. So in utero, it required active vasodilation to stay open. This vasodilation mechanism shifts depending on the gestational age. In early gestation, nitric oxide is the main relaxant. It works through the CGMP protein kinase G pathway to maintain ductal patency. As the fetus matures, prostaglandin E2, which is largely placenta-derived, takes over the dominant vasodilator. It acts via the EP4 receptor using CAMP protein kinase A pathway. Despite acting through different signaling routes, both mechanisms share common goal. They reduce intracellular calcium, which prevents smooth muscle cells in the ductal from contracting and closing prematurely. Normal postnatal ductal closure is regulated by complex interplay of molecular, structural, hemodynamical, and environmental factors. On the molecular level, closure is primarily triggered by a decrease in circulating prostaglandin and other vasodilators, along with increase in intracellular calcium level. The rise in arterial oxygen tension after birth also plays a central role in initiating ductal closure. But in preterm infants, immature oxygen sensing mechanism can delay this process. Structurally, there is structural factor like the Ductus arteriosus in preterm infants is underdeveloped with fewer contractile smooth muscle cell, immature intimal cushion, and lack of vasovasorum, all contributing to persistent patency. Hemodynamic factors such as blood flow and pressure might further influence ductal tone. And although thrombocytopenia has been linked to delayed closure, platelet transfusion has been shown as an effective method, implying that platelet function might be more critical than platelet count. Lastly, maternal and environmental influences, including infection like rubella and possibly Zika virus, as well as exposure to teratogens such as cannabis, both associated with higher incidence of PDA. So the etiology of PDA is multifactorial, varies depending on the gestational age. In a preterm infant, PDA is largely attributed to structural and physiological immaturity, whereas in term infants, genetic alteration are more commonly implicated. A distinction can be made between syndromic and non-syndromic form of PDA. Syndromic PDA, more frequently observed in term infants, it is associated with chromosomal abnormalities such as trisomy 21, 22q11.2 deletion, and single gene disorder like TAR syndrome. These syndromic PDA, they account for 10% of all PDA cases. Non-syndromic PDA, on the other hand, is believed to be result from multifactorial inheritance involving both genetic predisposition and environmental influence. Evidence from familial and twin studies support a heritable component, with term infants showing 2 to 4% recurrence risk among siblings and a higher incidence of monozygotic compared to dizygotic twin among preterm infants. However, research is limited by the lack of accessible human ductal arteriosus tissue, promoting the use of mouse models to explore the molecular mechanism underlying ductal regulation. So PDA, as epidemiology, PDA is the most common cardiovascular condition affecting preterm infants, with its incidence closely linked to gestational age. The risk of PDA is inversely proportional to maturity, with up to 50% of infants born before 26 of gestation exhibit presence of PDA beyond 2 months of age. In contrast, among term infant, PDA is significantly less frequent, occurring in approximately 1 in 2,000 live births, but still account for 5 to 10% of all congenital heart defects. Additionally, a subset of cases known as a silent PDA, where the ductus remain patent but without overt clinical sign, can only be detected through imaging. The prevalence of such silent cases might be as high as 1 in every 2 births, highlighting the importance of diagnostic vigilance even in the absence of symptoms. So in a neonate with presentative PDA, the postnatal drop in pulmonary vascular resistance facilitates the development of continuous left to right shunt from the aorta to the pulmonary artery. According to the Hagen law, The volume of this shunt flow is directly proportional to the pressure gradient between these two vessels and inversely proportional to the resistance within the ductus. Consequently, a large ductus with lower resistance allows for greater shunt flow, which can lead to more pronounced clinical consequences such as pulmonary overcirculation and systemic hypoperfusion. This relationship underscores the importance of both anatomical size and functional resistance in determining the hemodynamic impact of PDA. Also, we have the amount of blood flow through PDA is not only determined by the flow and the resistance, it's also determined by modifiable factors such as oxygen level and blood pH, which influence pulmonary vascular resistance. Infants with larger ductus experience a greater change in flow dynamic with alteration in systemic and pulmonary pressure. The left to right shunt in PDA significantly increase the pulmonary blood flow. This is a pulmonary circulatory consequences. With the excess volume stretches the left ventricle, leading to dilation and elevated end diastolic pressure. As a consequence, pulmonary venous pressure rise, predisposing the neonate to pulmonary congestion. These hemodynamics effects are particularly severe in preterm infants whose immature ventricle have limited compliance and increased elastance, making them less capable of accommodating increased preload. This exacerbates pulmonary edema and contributes to respiratory complication in affected neonates. Unlike adults, neonates have pulmonary vascular that is already nearly fully recruited and lack compliance. As a result, the increase in pulmonary blood flow leads to elevated pulmonary arterial pressure and pressure shifts into capillaries, promoting interstitial edema. This fluid buildup decreases lung compliance and worsens oxygenation, further compromising the respiratory function. Additional respiratory effects in PDA with larger shunt, left arterial volume and pressure increases even more, worsening pulmonary venous hypertension. This can lead to alveolar edema and deteriorated lung mechanics. And preterm neonates, especially those with RDS, respiratory distress syndrome, the increase in microvascular pressure causes exacerbated interstitial and alveolar fluid accumulation, which contribute to secondary surfactant dysfunction and impaired gas exchange. The systemic effects of PDA, the diastolic flow reversal in the descending aorta caused by the shunting of blood, reduces perfusion to abdominal organ. This phenomenon can be detected as absent or reverse in diastolic flow in vessels such as the celiac artery, superior mesenteric artery, and middle cerebral artery. However, only abnormalities in the middle cerebral artery flow have shown consistent association with neonatal morbidity. So defining hemodynamically significant PDA remain as a clinical challenge, especially in preterm infants. In this population, it is often difficult to determine whether the PDA is the direct cause of complication or simply associated with them. As a result, the definition of hemodynamically significant PDA in preterm infants typically relies on the combination of clinical indicator and echocardiographic parameter. In contrast, among term infants, older children, and adults, hemodynamically significant PDA is more clearly identified through echocardiographic evidence of cardiac volume overload, specifically enlargement of left atrium or left ventricle caused by increased pulmonary blood flow through the ductus. So this slide introduces the McNamara staging for hemodynamically significant PDA in preterm infants. It's a valuable framework that classifies PDA based on clinical severity and echocardiographic findings. I will begin with asymptomatic infants who show no clinical signs and have no detectable ductal flow into the imaging or Doppler. These infants have no PDA or only a closed ductus. Moving to mild symptoms, those preterm typically have a MAB of less than 8 millimeter mercury while receiving respiratory support, either CPAP or mechanical ventilation. Clinically, they might present with feeding intolerance. Echocardiographic echocardiographically, they show small, non-hemodynamically significant PDA with features like transductal diameter of less than 1.5, restrictive continuous ductal flow, no signs of significant left heart volume loading by looking at the left atrium aortic root ratio of less than 1.1, and no left heart pressure loading with EA ratio of less than 1 or normal isovolemic relaxation time. Then we transition to moderate symptoms where infants often require mechanical ventilation with MAP between 9 to 12 millimeter mercury ventilatory requirement. They also might have evidence of abdominal distension and or persistent vomiting. Echocardiographic features include moderate size VTA with size between 1.5 to 3 millimeter and restrictive pulsatile ductal flow, moderate left heart volume loading with left atrium aortic root ratio between 1.5 to 2.1, early signs of left heart pressure loading with AA ratio of more than 1, or isovolumetric relaxation time between less than 50 to 60 milliseconds. Decreased end-diastolic flow in major artery, including the mesenteric cerebellar adrenal circulation. Continues with severe symptoms where the PDA impose a substantial hemodynamic burden. Those infants typically have a MAP of more than 12 millimeter mercury and require high-level ventilation support, including high frequency. Clinically, they might present with marked abdominal distension and or erythema, including potential gut ischemia and necrotizing enterocolitis. And echocardiograph, those infants typically have large PDA with transductal diameter of more than 3 millimeter. They have unrestricted pulsatile transductal flow. They have severe left heart volume loading with left atrial to aortic ratio of more than 2.1, a mitral regurgitation jet of more than 2, severe pressure loading with EA ratio of more than 1.5 or isovolemic relaxation time of more than 60 milliseconds. Critically, reversal of end-diastolic flow in the superior mesenteric middle cerebellar adrenal artery. These findings reflect systemic hypoperfusion and high risk of morbidity, making this stage a key decision point for aggressive management. In older children, hemodynamically significant PDA staging is primarily based on PDA size and physiological impact of the shunt. We begin with silent or trivial PDA, which are asymptomatic and carry no clinical or hemodynamic consequences. Those children maintain normal exercise capacity, normal renal, hepatic, and pulmonary function. And a small PDA creates minor left to right shunt that is not classified as hemodynamically significant and do not restrict activity or cardiac function. Mild to moderate PDA present with more complexity. Those might exhibit mild to moderate left to right or bidirectional shunting. Clinical echocardiographic feature of early hemodynamically significant PDA with mild left atrial enlargement or left ventricular enlargement, mild left ventricular dysfunction, mild to moderate hypoxemia or cyanosis, signs of pulmonary hypertension. They can have potential for mild renal, hepatic, or pulmonary dysfunction. Now we focus on the large PDA in older children, where the ductal size and shunting pattern lead to substantial hemodynamic effects. Those children present with large left to right shunt, bidirectional, or even right to left shunt in presence of pulmonary hypertension. Severe left atrial enlargement, moderate to severe left ventricular dysfunction, moderate to severe hypoxemia or cyanosis, established pulmonary hypertension, critically a risk of developing Eisenmenger syndrome with reversal of the shunt direction and irreversible pulmonary vascular disease. This stage represents the most advanced spectrum of hemodynamically significant PDA, require urgent evaluation and often intervention to prevent long-term complications. So, in preterm infants, to know the clinical consequences of PDA in preterm infants. A persistent PDA is linked to a variety of serious clinical complications that are less frequently observed in older children or adults. Those include respiratory issues such as bronchopulmonary dysplasia, neurological concerns like interventricular hemorrhage, and GI problems like necrotizing enterocolitis. The immature physiology of preterm infants make them particularly vulnerable to the hemodynamic effects of PDA. However, despite significant research, it remains uncertain whether these adverse outcomes are directly attributed to PDA itself or influenced by the interventions such as pharmacological or surgical treatment used to close the ductus. This ongoing ambiguity continues to challenge clinical decision-making in the neonatal setting. So the respiratory consequences, as mentioned, we have a left to right shunt. This will increase the respiratory support and mechanical ventilation. It will lead to pulmonary overcirculation. It will increase the risk of bronchopulmonary dysplasia. And there is a risk of 3 to 23% of pulmonary hemorrhage. However, studies have shown that early PDA treatment, particularly by day 7, does not significantly reduce the risk of pulmonary hemorrhage compared to expectant management. Importantly, prolonged PDA exposure, especially beyond 7 to 14 days, has been linked to increased odds of bronchopulmonary dysplasia and even mortality. Still, it's unclear whether the PDA directly causes those outcomes. The neurological complication, it remains a significant concern of preterm infant with or without the presence of PDA. Prematurity itself increases the risk of interventricular hemorrhage, periventricular decomalacia, and subsequent neurodevelopmental delay. Prophylactic use of indomethacin has been shown to reduce the incidence of symptomatic PDA and need for surgical ligation. And it's also shown it also lowers the risk of severe IVF. However, studies have not demonstrated a clear benefit in terms of long-term outcome, such as mortality or neurodevelopmental status at 18 months, which has led to ongoing debate regarding its routine use. Currently, only a small percentage of U.S. hospitals administer indomethacin within the first 24 hours. And while some experts advocate for its discontinuation, others support more selective risk-based approach. Additionally, there are concerns that surgical PDA ligation might negatively affect neurodevelopment, although confounding factors make it difficult to draw definitive conclusions. The intestinal complications, particularly NIC, are significant concern in preterm infants with PDA. One of the hallmarks of PDA-related systemic compromise is reversal of diastolic flow, as mentioned before, in the systemic artery, including those supplying the gut. While this abnormal flow suggests impaired mesenteric perfusion, clinical trial has not demonstrated a consistent reduction in NIC incidence following PDA closure. Additionally, pharmacological strategy must be used cautiously, especially the combination of indomethacin and hydrocortisone, which is contraindicated due to marked increased risk of spontaneous intestinal perforation. So, although PDA is often better tolerated on older children and adults than in preterm infants, it can still result in serious complications if left untreated. The most critical long-term risk include progression to pulmonary arterial hypertension due to sustained left-to-right shunting, and eventually Eismenger syndrome if shunt reversal occurs. Additionally, a persistent PDA increases the risk of infective endocarditis, especially in cases with turbulence, flow, or endothelial damage. These complications underline the need for continued surveillance and timely intervention in patients with PDA beyond the neonatal period. For the pulmonary arterial hypertension, as mentioned, we have chronic left-to-right shunting throughout the PDA. It results in sustained high pulmonary blood flow and pressure. Over time, this hemodynamic burden induces structural remodeling of the pulmonary vascula, including medial hypertrophy, intimal fibrosis, and obstruction of a small arteriosus. Those changes progressively increase pulmonary vascular resistance that ultimately leads to pulmonary arterial hypertension. If left untreated, the pressure in the pulmonary circuit might suppress the systemic pressure, causing a reversal of the shunt direction from right to left, a condition known as Eismenger syndrome. Clinically, Eisminger presents with signs such as cyanosis and digital clubbing. In advanced stages, right ventricular failure emerged as the leading cause of mortality, underscoring the importance of timely diagnosis and intervention. For infective endocarditis, it's another potential, but it's a lot less common complication of PDA, especially in a newer age. Though historically it was considered a significant risk, modern estimates show relatively low incidence. Guidelines once supported ductal closure to prevent IE, but contemporary recommendation now limits antibiotic prophylaxis to the early post-closure period, reflecting a shift of understanding actual IE risk. So going into the diagnosis of PDA, echocardiograph is the cornerstone of PDA evaluation, especially in preterm infants, to provide a critical information on the ductal size, flow direction, and hemodynamically significance. Doppler imaging allows clinicians to assess the velocity and pattern of blood flow throughout the ductus, while two-dimensional image help visualize structural relationship and cardiac chamber enlargement. Key echocardiographic parameters include left atrium to aortic root ratio, ductal diameter, and signs of increased pulmonary blood flow or systemic hyperperfusion. This imaging modality is non-invasive, bedside accessible, and essentially not only for diagnosis, but also for monitoring the effect of therapy or conservative management. So echocardiographs, as mentioned, we can see this is an example of echocardiograph imaging of PDA. And the first image, we can see a colored Doppler imaging used to visualize the ductal flow, confirming a left to right shunt. And the next image B, it shows pulsatile flow pattern with low velocity and wide difference between systolic and diastolic phases, typically a less restrictive PDA. In contrast, figure C, it shows a restrictive pattern with higher flow velocity seen throughout both systole and diastole, suggesting increased resistance. Finally, figure D displayed bidirectional shunt characterized by right to left flow during systole, which might indicate elevated pulmonary pressure or evolving hemodynamic compromise. Those Doppler flow patterns are essential for tailoring management strategies and predicting clinical outcome. In addition to ductal visualization, we need to assess cardiac effects and hemodynamically significant PDA. So in the first image, image A, we can see dilation of both left atrium and left ventricle, suggestive of increased pulmonary venous return. This is quantified in figure B using M-mode, the one below it. In M-mode, we can see the LA, left atrium aortic root ratios, which serve as a key index for volume loading. Figure C shows elevated pulsatile pulmonary vein diastolic flow, further confirming increased left side reload. Additional Doppler indices such as shortened isovolumetric relaxation time, which can be seen in image D, and we can also see the mitral valve EA ratio of 1 in image E, which both reflects altered diastolic function. Lastly, the last image, it shows a reverse diastolic flow in the post-ductal descending aorta, which is a hallmark of significant systemic state. Together, these findings help quantify the impact of PDA on cardiac performance and guide treatment decision. So assessing the hemodynamic significance of PDA is a complex, cannot rely solely on ductal diameter. While many studies use size as primary marker, this approach oversimplifies multifactorial conditions. The clinical impact of PDA also depends on the duration of ductal patency, the direction of volume of shunting, and how will the systemic circulation compensate for those changes. For example, a small but persistent duct with high velocity shunting could still cause significant strain on the heart and systemic organ. Therefore, comprehensive evaluation is including echocardiographic markers for cardiac performance, and systemic blood flow is essential to guide appropriate and timely intervention. So, given these challenges, relying on traditional measure alone, as mentioned many times, such as the ductal diameter on only the left atrial to aortic growth ratio, can lead to inaccurate assessment. For example, with LA to aortic ratio, it's widely used to estimate volume overload, and it can be affected by unrelated factors like preload variation of myocardial compliance, which limits its specificity. Recent advances in imaging, particularly cardiac MRI, have emphasized the importance of flow-based assessment. Notably, reversal diastolic flow in the descending aorta has emerged as a more reliable and physiologically relevant marker for significant ductal shunting. These insights underscore the need for more used multi-parametric approach to evaluate PDA severity. So, continuing from the McNamara staging I just mentioned for preterm and older children, this slide presents more comprehensive and modern approach to define hemodynamic significant PDA. Modern assessment does not rely solely on PDA diameter, and instead it incorporates full echocardiographic profile, focusing on how much shunt volume contribute to physiological instability. We have also the El-Khafash PDA score. You can find it online. It uses it combines multiple echocardiographic and clinical parameters. It uses gestational age in week. It uses the PDA diameter in millimeter. It uses the left ventricular output in milliliter per kg per minute. Uses maximum PDA velocity in millisecond and meter per second. It uses the left ventricular E wave in centimeter per second. And this score have a range from 0, which is a low risk, and 13, where 13 is the high risk. According to randomized controlled trial, infants with a score of more than 5 or more were considered high risk for developing chronic lung disease or death, and were those randomized for intervention. This scoring system, along with McNamara, enhanced clinical decision-making by pinpointing which infants are most likely to benefit from early targeted therapy. So I will just go through this slide quickly. So to better assess the hemodynamic impacts of PDA, everything mentioned in previous slide, we have the PDA to LPA diameter. If the ratio is more than 1, it's considered significant. We have the flow pattern, antegrade, absent retrograde diastolic flow. Anything we'll consider abnormal and significant for PDA. We have the left ventricular output, if more than 300, secondary to increased preload. We have mitral valve EA ratio, if more than 1, it indicates PDA significance. We have the isovolumic relaxation time, if it's less than 40, if 40 is significant. We have the LA aortic root ratio of more than 1.6, it's considered significant. We have the pulmonary valve T wave velocity. If it's more than 0.5 meter per second, it indicates increased pulmonary valve return. We have the LPA and diastolic velocity. If it's increased, it leads to increased mean and diastolic flow velocity. All of these findings are significant for PDA. So going for the older patient, particularly those with elevated pulmonary vascular resistance, standard transthoracic echocardiograph may not provide sufficient diagnostic clarity for PDA. Transesophageal echocardiogram, although more advanced, still faces limitation, particularly with color Doppler interpretation where right to left shunt is present. Consequently, advanced imaging such as cardiac MRI or CT increased utilized to detect PDA and assess ductal characteristics. The cardiac MRI, it's considered gold standard for non-invasive evaluation of PDA in older patients. It offers superior insights into blood flow dynamic and anatomic structure without radiation exposure. Meanwhile, CT, especially cardiac-gated scan, can identify complications like calcification and thromboembolic disease. essential for planning interventions such as PDA closure. In adult patients, particularly with suspected pulmonary hypertension, cardiac catheterization plays a central role. It helps determine whether PDA closure would be beneficial or harmful. In some cases, the PDA function as a pop-off valve for the right ventricle, relieving pressure. Closing the ductus in this setting might trigger right heart failure. So we need to do test occlusion, which help evaluate physiological response and safety of closure. We have the American Heart Association guideline for non-infant hemodynamically significant management. Let's start with the echocardiographic assessment of shunt direction. Then we have to see and evaluate for pulmonary hypertension and infective endocarditis. Depending on these findings, if the patient considered to have pulmonary hypertension, going with no closure and pulmonary vasodilator are more beneficial. If we still have a left to right shunt, we can either consider closure or continue follow-up for this patient. So going into therapy, after everything we just said about comprehensive echocardiographic assessment and identification of hemodynamically significant PDA, the next step is determining the most appropriate treatment strategy. Pharmacological closure is often the first-line approach in preterm infants, especially where there is evidence of significant shunting or clinical instability. Among available options, we have non-steroidal anti-inflammatory drugs, which have been the cornerstones of medical management. Indomethacin and ibuprofen, two of the most widely used NSAIDs for PDA treatment on this population. Both function by inhibiting cyclooxygenase, reducing prostaglandin synthesis, and promoting ductal constriction. Indomethacin is well established in its ability to promote closure, but it's not associated with improvement in survival or long-term outcome. It also carries risk of oliguria, renal dysfunction, and spontaneous intestinal perforation, particularly when used in conjunction with corticosteroids. Ibuprofen, on the other hand, it offers similar efficacy in closing the ductus, but with fewer renal and GI side effects. Evidence also supports oral ibuprofen as more effective than IV form, leading to increased preference in many NICUs. While NSAIDs remain the standard for pharmacological PDA closure, interest has grown in alternative therapy that might offer improved safety profile, especially in vulnerable preterm infants. Acetaminophen has emerged as a promising candidate, with early studies suggesting similar efficacy to traditional agents like ibuprofen and indomethacin, but potential fewer side effects. However, current body of evidence remain limited, and larger, high-quality trials are needed to validate its role in routine management. Additionally, variability in drug response among preterm infants has brought attention to pharmacogenetic influence. For example, indomethacin metabolism rely on the CYP2C2 9-NUGT enzyme in the liver. This enzyme system might be immature in preterm neonates, and certain genetic variant can further modulate both drug efficacy and risk for adverse effects. This insight underscored the shift toward individualized PDA treatment, where therapy selection could eventually be guided by genetic and metabolic profile, enhancing both safety and effectiveness. So, building on the evolving landscape of PDA management, surgical ligation has shifted from widely used intervention to more selective last resort option. Although it provides definitive closure, its association with increased morbidity, such as post-ligation cardiac syndrome, bronchopulmonary dysplasia, and potential neurological or vocal cord complication, which raised concern for its long-term safety. Moreover, the lack of clear survival or neurodevelopmental benefit has led many centers to reserve surgery only for cases where medical therapy failed or when PDA case causes significant hemodynamic compromise. This decline in surgical use reflects a broader trend toward minimally invasive approach, with an emphasis on balancing the need for closure against the risk of intervention. Following the decline in surgical ligation, transcatheter PDA closure represents a promising frontier in the treatment of preterm infants with significant ductal shunting. Leveraging technology advancement, particularly devices like the implanted buccal occluder. This approach allows for safe and effective closure even in extremely low birth weight infants, often under 1 kg. The use for femoral venous access over arterial route has significantly minimized procedural trauma and vascular complication. Despite high procedural success and favorable safety profile, key question remains regarding long-term outcome, especially when compared to conservative or medical therapy. As a result, while transcatheter closure is gaining momentum, its place on routine clinical pathway continue to be shaped by emerging data and individualized risk-benefit assessment. This slide demonstrates the technical process of transcatheter PDA closure using fluoroscopy and echocardiographic guidance. As shown in the first image on the right side, the figure, the procedure begins with femoral venous access. A catheter is advanced through the right heart chamber across PDA into descending aorta, guided by soft-tipped wire. The initial catheter is then exchanged for delivery sheath, throughout which the closure device is advanced. Under combination of fluoroscopic and echocardiogram, the device is carefully positioned within the PDA to avoid protrusion into the adjacent structure before final release. And the images on the right side, we can see actual images from previous PDA closure. This visual highlights the precision and minimally invasive nature of this technique, which has made it an increasingly attractive option for PDA management and selected preterm infants. So, as I said, transcatheter technique gained ground, surgical intervention now reserved for selected cases. There has also been notable rise in conservative management strategies for PDA. This approach stands in contrast to active closure, aiming instead to support the infant while allowing for spontaneous sexual closure. The clinical care focus on measures such as fluid restriction, optimized respiratory support, and care for hemodynamic monitoring. The shift toward this strategy reflects increasingly evidence that routine closure, whether medical, surgical, or transcatheter, does not always improve outcome, particularly in infants without clear signs of hemodynamic significance. However, its application remains nuisance. In extremely preterm with clinically unstable infant, the risk for leaving significant PTA untreated are still under debate, and ongoing studies continue to explore whether early targeted treatment or expectant management is safer for this vulnerable group. So building on the evolving treatment landscape, the timing of PDA intervention has become one of the most debated topics in neonatal care. Historically, early treatment, often within the first few days of life, was pursued under the belief that it would be more effective and prevent complication. However, emerging evidence, including findings from the PDA Tolerate trial, challenged this approach. Studies now show that successful pharmacological closure is still achievable even when therapy is delayed until the 3rd or 4th week of life, suggesting that there might not be narrow therapeutic window. This shift supports more individualized strategy in which treatment decisions are guided not by rigid timeline, but by infant clinical condition, echocardiographic findings, and response to supportive management. For post-discharge PDA management and preterm infants, it's common among preterm infants to have spontaneous closure post-discharge. It usually occurs even beyond 1 to 2 years of age. There is multiple study with Herman study showed that 86 of preterm infants have spontaneous closure after discharge, and there was a multi-center study showed that there was spontaneous closure in 47% by 12 months and 58% by 18 months. However, there is no standardized outpatient monitor protocol, so long-term risk and outcome remain under investigation. Going into the term infants and beyond, pharmacological treatment have no effect on older patients. They lose efficiency beyond, especially NSAID, they lose efficiency beyond early infancy. So clinicians rely more heavily on clinical assessment and imaging to determine the need for intervention. When the PTA is deemed hemodynamically significant, typically characterized by the previously mentioned aspect. Usually they go for other methods that I will mention now. First, we have the mainstay treatment, which is the transcatheter closure. So when outpatient monitoring identify a hemodynamically significant PDA in older patient, particularly with signs like pulmonary overcirculation or left heart enlargement, closure becomes the next step. For children over 6 kg, this approach is both safe and effective, with high success rate across most types, except type B, which is the window type, due to its anatomy. The 2011 AHA guidelines support the strategy recommending closure in cases of left to right shunt with clinical consequences such as failure to thrive or heart failure. This is a class 1 level B recommendation, reflects strong expert agreement and solid clinical evidence. So if we have a patient with PDA and pulmonary arterial hypertension, management requires careful evaluation before closure. As mentioned before, they tend to the pulmonary arterial hypertension results from excessive pulmonary blood flow rather than irreversible vascular disease, meaning closure could still be beneficial if reversibility is demonstrated by balloon occlusion in cath before. So in more advanced cases where the PVR exceeds 5 and their shunt ratio is below 1.5, closure is often contraindicated. For those patients, particularly with Eisenmenger syndrome, supportive therapy like endothelin receptor antagonist and phosphodiesterase 5 inhibitor can improve symptoms and survival. Ultimately, individualized risk stratification and by imaging hemodynamic testing is key to determine whether PDA closure is feasible or if medical management is the safer for both path forward. When transcatheter closure fail, we can go to surgical ligation. Transcatheter closure is preferred, but not always feasible. It can also fail due poor ductal morphology or due to other factors, or due to associated vascular anomalies. In these situations, surgical ligation serves as dependent fallback option, offer definitive closure when catheter-based methods are not viable. We have minimally invasive techniques like the video-assisted thoracoscopic surgery, which have increasingly replaced traditional thoracotomy. Both methods have high success rate, low complication rate, refining its continued relevance in selected patient population. For silent or small PDA, historically, even those patients were closed prophylactically to prevent infective endocarditis, a field complication at that time. However, with advanced effective antibiotic therapy and refined risk stratification, this approach to this lesion have evolved. Current guidelines no longer advocate for routine closure or prophylactic antibiotic in silent or small PDA. So in conclusion, as our understanding of PDA has matured, so too has the realization that one-size-fits-all approach is no longer appropriate. The shift away from routine closure of a small or silent ductile toward more nuisance evidence-derived decision reflects this evolution in care. Building on this foundation, future direction in PDA management must embrace personalized medicine, recognizing the diverse clinical presentation and therapeutic response across patient population. This required a deeper dive into the molecular underpinning of ductal physiology, alongside the integration of biomarker imaging and genetic data into a risk-based decision framework. Only through pragmatic outcome-oriented trial can we refine our strategy and ensure that each patient receives the most appropriate and effective care. That brings us to the end of this presentation of PDA. I would like to thank you again for your time